So good afternoon, everyone. I'm Van Hock Tan from the Singapore General Hospital. I'm an infectious disease physician, and I'm also on the Executive Council of the Asia Fungal Working Group. So the AFWG is very happy to host yet another in the Fungal Frontiers series. And we are very happy to partner the mycosis study group of the Australasian Society of ID to bring this series to all of you. And this is about the 7th that we have done. We've always had a very good participation. And I think it's good that we are doing something at an earthly hour for our region. So today we had an interesting session on dermatophytes, several very good speakers. And it's my pleasure to introduce first my co-chair, Sharon Chen from Westmead in Sydney, who actually needs no introduction. She's been on many, many guidelines, and she's a big force in the field of medical mycology. So I think Sharon will kick off today's session with her talk. After that, we'll have Catriona Halliday also speaking to us on some of the laboratory aspects. So let's call upon Sharon first.
Right. Thank you, Van Hock, for your very kind introduction. And I hope the topic will be of interest to everyone here tonight. Can you see my slides? I hope. Yes?
Yes.
Okay. So for those who have been to these webinars, we usually start off with a case report, and then we twirl around the case report and discuss various aspects. But because the changes in dermatophyte infections in Australia aren't being surveyed systematically at the moment, it was difficult to know how to present this, and therefore this webinar is a little bit more didactic than normal. But we do have our last talk given by Sunil Dogra, who is a dermatologist in India, who has a lot of experience on treating resistant Trichophyton infections. And I'm really looking forward to that aspect of the webinar later on. Not that I'm not looking forward to the rest of the webinar. Anyway, so I thought I would kick off by emerging clinical perspectives. And this is really what, goes through the clinician's mind when we think about dermatophytes and what changes you might expect to see in this disease entity. I would firstly like to acknowledge country. So we, being the ANZMIC and AFWG, acknowledge the Aboriginal and Torres Strait Islander people of Australia and their special place in the culture of this land. We also pay our respects to elders past, present, and emerging, and hold the memories and the traditional cultures and hopes of all Aboriginal and Torres Strait Islander peoples. These are my disclosures, and I'd like to thank both ACID and the AFWG secretariats, which have worked very hard to realize this session. So what I thought I'll do tonight is to look at how dermatophyte infections have changed in scope. What would trouble you if you saw someone with a suspected dermatophyte infection? Have they got deeper? So are they more invasive? Have they gotten more extensive? Are there changes in epidemiology, such as their propensity to cause outbreaks and, more recently, their propensity to cause sexually transmitted disease? Are there new species, which we will talk about a lot more? And are they more difficult to treat? And in the middle of this is the drug resistance issues that has been seen globally. Now, dermatophytes are probably one of the few entities that most hospital ID physicians would think about because it's not really in their domain to look after patients with dermatophyte infections, but they are a very common entity and they affect about 25% of the global population. That's a huge number of people. One slide on classification. Like all fungi, they belong to a phylum. Ascomycota. They belong to a class, an order, a family, and importantly, there are 7 clades, A to G, of dermatophytes. The 4 main ones are Trichophyton, Epidermophyton, Nenissia, and Microsporum. But there are newer clades as well, such as the Paraphytons and the Lophophytons, and most recently, Arthrodermis. There are more than 40 human pathogenic species, and because dermatophytes can lyse keratin, they tend to affect the skin, the hair, and the nails. They can colonize all these sites. They are most prevalent in hot, humid environments and can stick on household items. And beware going barefoot in hotel rooms because they can stick on carpet hair as well. Now, with all the new species and with all the hype of resistant dermatophytes, T. rubrum still remains supreme despite the changing epidemiology. And you can read all about it in these 2 references down below, which are very comprehensive but very self-explanatory. We can also group dermatophytes with respect to their ecological and clinical parameters, and these are clinically useful. So for instance, according to their phylogeny, their sexuality, whether they give rise to highly inflammatory or non-inflammatory infection, and how they're transmitted. And there are 3 main groups. So geophilic, of the soil, zoophilic, of animals, and anthropophilic. I was going to say of man, but it's actually of persons because they can affect both sexes in equal proportions. They can cause tinea of the hair, of the body, of the beard, of the groin, of the feet, almost any site. And depending on whether they're geophilic or zoophilic or anthropophilic, they may vary in their propensity to cause infection at any one site. Let's just go and take Tinea capitis as an example. We find that all 3 can cause Tinea capitis. But if we go down to Tinea barbae and Cruris and pedis, you find that the soil dermatophytes do not cause infection in this region. Example species are shown on the last line. And again, using Tinea capitis as an example, M. canis is the most common species of the zoophilic group, whereas T. tonsurans is the most common species in the anthropophilic group. So it's a useful classification. So just to look at trichophytons a little bit more, and I think the remaining 3 speakers may speak a little bit more about the clades and what they all mean. There are 4 main subclades, A1, A2, A3, and A4. So Mentogrophytes series, Benhamii series, Bullosum, and T. rubrum complex. You know that some are called series and some are called complexes. And I think this just represents the fact that the taxonomists have not quite made up their minds on how to classify T or trichophytons absolutely correctly. Let's go and look at extensive disease, and this overlaps of new species. So what do we mean by extensive disease? I mean, it's kind of a nebulous term. It means that there's an unusual extent of the skin that's infected or that multiple sites are infected. So usually a dermatophyte infection is limited to the stratum corneum, so the most superficial layer. And usually if it's a deep disease, it's in immunocompromised hosts. But we're starting to see deep disease and extensive disease in immunocompetent patients. Suddenly in comes in Trichophyton indotinei, which we'll talk about more. And this species is known to affect most sites, multiple locations, multiple lesions, and give rise to severe and highly inflammatory and painful itchy lesions. It is said to follow the use of steroid creams. It can be chronic and relapsing, and it causes outbreaks, human-to-human transmission. More about diagnosis and treatment later. But dermatophyte infections can invade and yet not invade extensively. And when they do this, they can be misdiagnosed as any other infection, such as eczema, other skin conditions, and you name it. You usually see these in solid organ transplants or in immunodeficiency states. But more recently, we've seen it in inheritable immune deficiency, HIV/AIDS patients, and in hematology conditions. There are two main entities. The first is Majorschi's granuloma, which is deep follicular, perifollicular tinea corporis, giving rise to granulomatous suppurative inflammation. Or it can be classified as deep dermatophytosis, which extends beyond the perifollicular area, giving rise to painful plaques and nodules. And these frequently occur on the lower limbs. And the pictures on the right-hand side show you some lesions in a renal transplant patient. So what they look like macroscopically and clinically, and then there's a histopathology picture showing hyphae on PAS staining. These are some more examples of extensive infection. People with extensive tinea corporis and tinea cruris. This may not look extensive or may not look highly inflammatory, but it was still a lot worse than it could have been. And finally, here is a patient seen some years ago now in Queensland with deep-seated Trichophyton rubrum infection. It just did not affect the leg, but it infected the arms as well. And it was biopsy proven and in the end resolved with months and months and months of terbinafine. So we've talked about Trichophyton indoteniae, at least we've introduced it, and Sarah's going to talk a lot more about it. But basically, this species emerged in India, then it went to Iran and Singapore, and now has spread globally. It's important because many, many strains are terbinafine resistant. We think it should be separated from T. mentacrophytes, but taxonomically, this is incorrect. However, the experts have decided that the new name is clinically relevant, so it's going to stick until we can resolve this very interesting argument. It's a casualty of reclassification. It's a clonal anthropophilic fungus, as opposed to the zoophilic T. mentacrophytes, but it has since been found in dogs in India, so it could be zoophilic as well, but anthropophilic in transmission. So the jury is still out. AFLP and WGS studies support T. indoteniae as a separate species. It can cause all forms of tinea. Travel is a risk factor. It's a public health concern, person-to-person spread and through fomites. But the burden, at least in Australia and New Zealand, is uncertain due to inconsistent diagnostics, which Sarah will talk about. But we have encountered it in Australia. These are just a couple of reports published by Kira Chua in Melbourne, who works in a very large Melbourne private pathology lab. Of 202 specimens looked at retrospectively, T. rubrum caused most of these infections, 60%, but T. indoteniae caused 6.4%. And the important thing is that a third of the T. mentacrophytes, T. indigitale isolates turned out to be T. indoteniae by ITS sequencing. Genomic studies of indoteniae also abound. There are multiple studies from India, from Singapore, and I've just shown you the graphic from the Singapore study, which shows the KMA analysis performed on the Indian sequences as opposed to the Singapore sequences and some other Indian sequences. The USA has also published on this quite recently, and shown that their isolates cluster and are separate from the clusters of Indian isolates. So we have good tools to study this new species. It's important because it's drug resistant. It's resistant to terbinafine. It could also be resistant to azoles, although the prevalence will vary with geography. T. rubrum and T. indigitalia also can be resistant to terbinafine and to azoles, and the kind of forerunners of the point mutations in the squalene epoxidase gene for terbinafine resistance I've shown here. So there's 2 amino acid substitutions that one always looks for, but there are others as well. And for azole resistance, it's the common culprit in your efflux pump transporters, MDR2 family, MDR3 family, but also the mold equivalent of your ERG11, known as the CYP51B gene. So lots and lots of food for thought. This slide I thought was interesting and, to just summarize some key learning points, you have your species of Trichophyton, you have the resistance mechanisms, and you relate the resistance mechanisms to the drug that it's resistant to. So taking into tenii, here are your SQLE gene, point mutations, which give rise to terbinafine resistance, and here is your ERG and CYP51B cousins that will give rise to itraconazole and voriconazole resistance. And you can do this catalog for any species of dermatophyte that you may wish to study, and these are just a few. What about the shifting epidemiology? I think everybody here is, well versed with the epidemiology of dermatophyte infections. We know that zoophilic infections occur worldwide, although they may vary. They may vary temporally. They may vary with social economics. They may evolve with ecological factors and animal trade. There have been 2 groups of reports in the more recent literature. The first is Trichophyton benhamii, reported in Japan and Germany. Commonest pathogen in 1 German center. Perhaps they're very good at speciating this one. It's difficult to know because you don't know what their usual practice is like. And it's been linked to infected guinea pigs in farms, guinea pigs in shops, small rodents, camels, but also cats and dogs. And then there's the other Trichophyton, quickenum, rare in humans prior to 2015, but since then has arisen in Europe. The recent COVID pandemic saw the rise in both of these species, particularly in Germany. And you can read all about it in the publications down here. I think, although they are German journals, there is an English translation. And finally, I just want to talk a little bit about sexually transmitted infections. So we're familiar with the concept of tinea gladiatorum, where you might get dermatophyte infections from close and heavy physical contact, including visiting spa baths. But other modes of transmission are also possible. And before designating any infection to be transmitted through an STI situation, it should be a diagnosis of exclusion. In 2002, however, female sex workers noted a rise in a new infection, if you like, with lesions in the genital areas, in the buttocks, in the face, and they all had other risks for STIs. Many species can cause this, but T. mentogrophytes genotype 7 emerged as the one to worry about. And in 2016, there was an explosion or a mini explosion of cases in Berlin, in Paris. These numbers look small, but now there are many, many more, and it's ongoing, particularly in HIV-infected men and men who have sex with men. These lesions are highly inflammatory, as you can see by the pictures on the right-hand side. And I'm sure you would have encountered this article late last year, where it was noted in New York City and, caused a little bit of anxiety amongst the ID and STI community, where, there was talk about surveillance, there was talk about access to diagnostics. The CDC in its iteration then was going to inform and carry out some kind of surveillance. And there was talk about how we differentiate this from, say, Mpox, and whether we should be using multiplex PCRs to diagnose all these STIs together. More pictures of T. mentogrophytes genotype 7 in the moustache, in the beard area, in the groin, and in the perianal area. The last panel does show perianal Mpox in association with TMV. So a lot of thoughts to go into how we can optimize diagnostics. This was a systematic review, which I would commend. This was published this year, very, very recently. And it summarizes all the facts that we've talked about, mainly in men, multiple countries, travel, sexual intercourse, transmission to partners. Some cases were linked to gym and sauna use, and there were clusters links to, having going for a massage as well. So the bottom line is that it's necessary to implement a screening service that can properly diagnose and detect this dermatophyte infection to facilitate prompt public health response. And indeed, we do need an awareness campaign. There are more recent genomic studies. These are all ongoing. And this one that is appearing in medical mycology with this project number, if you want to look it up. And they talk about various things, but they also talk about how we might best identify TM7. And in fact, there's a recommendation that's going to come out that TEF1 alpha and tubulin B sequencing is preferred over ITS sequencing. So the conclusions from this clinical section are that we need to better understand how we classify dermatophytes. We need to better understand the global epidemiology and the reservoirs of infection, promote awareness about new epidemiology and new species among frontline clinicians. We need to beef up our diagnostics. We need to develop guidelines for antifungal susceptibility testing. And indeed, how would you want to do this? By broth microdilution or another method? We need more new antifungals, but that is something we're not going to solve tonight. And we do need surveillance, a One Health approach. And again, surveillance is something that doesn't come easily. It is expensive. It needs to be carefully thought, and it needs to be supported by governments. I just mentioned there are new non-drug treatments, such as laser and photodynamic therapy. And with that, I'm happy to, I think we will defer questions till the end. So if people could list their questions in the chat, I would be very appreciative. Thank you.
Thank you, Sharon. Very illuminating talk. So the stage has been set. Like she said, we'll take questions at the end of all the talks. Please key in the questions if you have any into the Q&A box. So now it's my pleasure to call upon Dr. Sarah Kidd, who's from the National Mycology Reference Center in Adelaide. And she'll talk to us about the diagnosis of Trichophyton infections, new Trichophyton species, culture versus culture-independent techniques. Sarah, please.
Can you see my slides?
Yes, we can,
Yeah.
although you're a bit soft.
Not sure how to change my microphone. Okay, so thanks for that introduction. And as Sharon has alluded to, I think the difficulty that we do face now is how we identify these emerging dermatophytes, and particularly those associated with new risk factors and resistance. So those are my disclosures, and the only one that might be relevant to this discussion is that I have in the past received some travel benefits from Oz Diagnostics. So as we know, dermatophyte infections have an estimated global prevalence of around 25%, which is a huge number of people, commonly presenting as tinea pedis and onychomycosis, tinea corporis, and tinea capitis. The gold standard for diagnosis is microscopy and culture, but molecular diagnostic methods are increasingly being used. However, the emergence of Trichophyton indotineae and the T. mentogrophytes genotype 7 presents a challenge for accurate identification and therefore the surveillance of these emerging pathogens. So direct examination of skin scrapings, nail or hair samples allows us to visualize dermatophytes in the specimen, but it requires the use of a clearing agent, typically potassium hydroxide, and this has good sensitivity if it's used in conjunction with an optical brightener stain such as calcofluor white or blancophore, but the sensitivity is much lower if no stain or a non-fluorescing stain is used. With experience, we can usually differentiate dermatophyte hyphae from other fungal elements such as non-dermatophyte molds or yeast pseudohyphae, but we cannot identify the genus or species. Culture requires specialized media such as lactritmal agar with antibiotics and cyclohexamide to minimize overgrowth of other skin flora and contaminants. It can take up to 3 or 4 weeks to grow a dermatophyte, and the sensitivity is only 40 to 60%. If we are able to grow the fungus, the specificity is good, but somewhat dependent on the skills and experience of the laboratory staff. Identification requires significant experience, careful examination of the colony and microscopic characteristics, and even more specialized media to examine the phenotypes. So I'm going to focus now on the identification and differentiation of Trichophyton indotineae from other species and genotypes of the T. mentogrophytes complex, as well as a little bit about identifying the T. mentogrophytes genotype 7, which, as Sharon has already told us, has been associated with an emergence of sexually transmitted dermatophyte infections. So the identification of Trichophyton indotineae is difficult, and we need to have a high index of suspicion. So clinical notes are very important, and we should be alert for hints that the infection is recalcitrant to treatment, presenting as extensive inflammatory lesions, possibly with multi-site involvement. And depending on where you are in the world, travel history is also important, particularly travel to the South Asian subcontinent. It closely resembles Trichophyton interdigitale and mentogrophytes by its morphology, and colonies are typically white to cream buff on the surface, perhaps with a downy to granular texture, and a yellow to orange reverse colour. Now, having said that, the yellow to orange reverse colour could potentially serve as a clue that this may be Trichophyton indotineae, because T. mentogrophytes and T. interdigitale colonies often have more of a yellow-brown to reddish-brown coloured reverse. Now, that's certainly not a reliable feature for accurate identification, but it could be used to add to a range of characteristics that could push you towards suspecting Trichophyton indotineae. Microscopic features are also very similar to the rest of the T. mentogrophytes complex, with round microconidia in clusters, smooth-walled multiseptate macroconidia, and some coiled hyphae. A phenotypic test that can be quite useful is urea hydrolysis. So when inoculated on urea agar, Trichophyton interdigitale and Mentogrophytes are typically positive for urease activity within about 4 days, turning the media from yellow to pink. T. indotineae, however, is typically urease negative after 7 days, or perhaps just weakly positive, and so the media remains mostly yellow. This is also not diagnostic, but it could be used for screening T. Mentogrophytes complex isolates to select out those that are potentially Trichophyton indotineae to be sent for definitive identification. Now, I don't think there are many labs left that use the hair perforation test routinely, and I've never actually performed this test myself. But it may be interesting to note that T. Mentogrophytes and interdigitale isolates almost always elicit positive hair perforation tests, while T. indotineae isolates typically do not perforate the hair shaft. There's also the tween 80 opacity test for lipolytic activity of dermatophytes. So T. interdigitale and Mentogrophytes isolates almost always elicit a positive or weakly positive result, where an opaque zone of appears in the media surrounding the colony. For T. indotineae isolates, these can also quite often be positive. About 25% though of isolates are negative in this test and do not produce that zone of opacity. Now, while the authors of the study found that 25% difference to be statistically significant between T. indotineae and T. interdigitale Mentogrophytes, I would suggest that the utility of this test as a screening tool is probably minimal. Oops. MALDI-TOF mass spectrometry does have the capability to differentiate T. indotineae from other Trichophyton species. However, it's not yet represented in commercial databases. But there is an online MALDI-TOF identification tool called MSI2. This was developed by Sorbonne University in Paris with the Belgian collection of microorganisms, and it's devoted to MALDI-TOF spectra identification. It contains T. indotineae spectra that were obtained from a range of culture conditions, and it was determined that the presence or absence of spectral peaks at around 6,800 Daltons from isolates at 7 to 10 days of growth provides the best discrimination of T. indotineae from closely related species, with a very high specificity of 99.6%. And so perhaps it won't be too long before we see Brooker and bioMérieux add T. indotineae to their databases. Definitive identification can be achieved through DNA sequencing of the internal transcribed spacer region, or ITS region, of the ribosomal DNA, as Sharon has told us already. However, it is important to be aware that there are only 1 or 2 nucleotides difference between genotypes of the Mentogrophytes complex, and so careful sequence analysis is critical here. And comparison of sequences to GenBank can be problematic, as it contains many sequences from isolates that have been, I could say, misidentified, but we could also say that they've been named using the previous nomenclature of Trichophyton Mentogrophytes. But there are reference ITS sequences for T. indotineae and all of the other genotypes of the T. Mentogrophytes complex. And these are published in the paper by Erlash in Journal of Fungi from 2022. And we use those reference sequences to assist in the identification of all isolates in the T. Mentogrophytes complex. Sequencing of the high mobility group, or HMG gene has been also shown to produce very distinct clustering of Trichophyton indigeniae, interdigitale, and mentogrophytes with very clear separation of these species. So this can also be used for reliable species identification. Currently, Trichophyton mentogrophytes genotype 7 cannot be differentiated from other isolates in the mentogrophytes complex by its colony or microscopic morphology, by any of its phenotypes, or by MALDI-TOF. So identification of genotype 7 is very difficult at this time. The only way really to reliably identify genotype 7 is by ITS sequencing, using those reference sequences that I mentioned previously in the paper by Erlash et al. From 2022. This is beyond the capabilities of most laboratories, but you could consider referring any T. mentogrophytes complex isolates from Tinea genitalis cases for sequence-based identification or typing. Now, I did just learn from hearing Sharon speak that TEF1 was also a useful, or was about to be announced in a new guideline on the identification of T. mentogrophytes 7. I haven't included anything about that in this presentation, though. Dermatophyte PCR is increasingly being incorporated into laboratory workflows, and this is between 20 and 30% more sensitive than culture. And obviously the turnaround time is significantly reduced compared to culture. So there are many benefits, but an important limitation of the current offering of commercial assays is that they often only identify to genus or species complex level, and they're unlikely to differentiate emerging species of interest at the moment. So there are a number of commercial assays on the market for detection of dermatophytes directly from specimen, and most have regulatory approval. Some are validated to detect dermatophytes from nails only, while others are validated for a whole range of specimens, including even formalin fixed tissue in some cases. The range of species detected varies between assays. So, for example, the SSI Diagnostica assay, which was one of the first to be developed, has a pan-dermatophyte target as well as just a specific target for T. rubrum and a specific target for Candida albicans, and that's all that it can specifically identify. But other assays detect a much wider range of genera and species, as you can see. There's only one assay that differentiates between T. interdigitale and mentogrophytes, and this dermagenius assay can even identify one of the other mentogrophytes genotypes, not genotype 7 though, it's actually genotype 4. So I'm not quite sure why that would be relevant to know, but that is a feature of this particular test, and it shows what's possible. The sensitivity and specificity of these assays is generally good, but it's also important to assess whether they're suitable for your local epidemiology. So, for example, a study based in Senegal in West Africa evaluated one of the Eurobioscientific assays, but they found there was a sensitivity of only 65%. And this was because there is a high prevalence in that region of Microsporum udonii, Tinea capitis, which this assay has no target for. None of these assays can specifically identify Trichophyton indigeniae or mentogrophytes genotype 7. These would just be detected as T. mentogrophytes complex. Having said that, I am led to believe that there is a new Oz Diagnostics, or our Biopharm, they're now called, dermatophyte panel set to be released before the end of this year, which does differentiate T. indotiniae from the rest of the Mentogrophytes complex. There are a few recent publications describing in-house developed assays to detect T. indotiniae, which look like they may have some promise, but require further validation to understand their utility in the clinical setting. Kaplan et al. Developed a quantitative PCR that detects a fragment of DNA that they determined by whole genome comparisons to be unique to T. indotiniae. And Ruhi et al. Described a cybergreen real-time PCR assay that targets 2 loci unique to Trichophyton indotiniae. And the sensitivity and specificity of these assays was good, but they've only been tested on cultures, and they only detect T. indotiniae. However, Baron et al. Used a dual quantitative PCR pan-dermatophyte assay where Trichophyton indotiniae can be differentiated from other dermatophytes by the difference in quantification cycle values. And specificity and sensitivity were 100% following validation in more than 100 skin samples from patients with confirmed dermatophytosis. And I was unable to find any published assays that could detect T. mentogrophytes genotype 7. So there remains an urgent need for more accessible diagnostic methods for T. indotiniae and emerging genotypes of concern. Urease screening is useful for identifying potential T. indotiniae isolates, which should then be confirmed using molecular methods. MALDI-TOF is improving, but T. indotiniae is not yet represented in commercial databases. Currently available commercial PCR assays do not differentiate T. indotiniae from the T. mentogrophytes complex, but this may change soon. For now, definitive identification of T. indotiniae requires DNA sequencing, either of the ITS region or HMG gene, and only ITS sequencing can identify T. mentogrophytes type 7, according to currently available guidelines. Comparison to reference sequences is critical for this. And with that, I will stop there and thank you for listening.
Thank you, Sarah. And thank you, Banhok. We will hold questions. Please put your questions in the Q&A rather than the chat. I can see one, so I've written it down. And we will move to our next speaker now. So our next speaker is Dr. Catriona Halliday, also from Westmead Hospital. Catriona and I work as a team, and I mean Sarah and I work as a team also, except we're not quite in the same building. And Catriona has done a lot of work on fungal diagnostics and fungal susceptibility testing. And she's allowed me to twist her arm to talk to you about dermatophyte susceptibility testing tonight. So, Catriona, take it away. Catriona? Yep, okay.
Just, can you see that now?
No, yes.
Yes? Okay, excellent. Thank you, Sharon, for the introduction. There we go. Okay, so I thought I'd just start with a bit of an introduction as to why and when we perform susceptibility testing for fungi, and then move towards why we would potentially do it for, I'm just trying to move this, sorry. Okay, but why we would do it for dermatophytes. So we perform susceptibility testing to determine the in vitro activity of a drug, or its MIC, to basically predict whether we think a patient is likely to respond to treatment. And as a general rule, we would perform susceptibility testing on all sterile site specimens, on isolates that have come from infections that might be invasive, relapsing, or failing therapy. And it's particularly important when to do susceptibility testing when you can't reliably predict the expected MICs based on species identification alone. So in particular, it's important when inherent or acquired resistance is a possibility for things like Candida auris, for Nicasiamyces glabratus or Candida glabrata, and for azole-resistant Aspergillus fumigatus. But it's also really important to perform susceptibility testing to get an understanding of your own local MIC data for resistance surveillance, for epidemiological studies, and also to kind of understand the performance of both new and existing agents against various organisms. So then why do we perform susceptibility testing on dermatophytes? I've asked myself this question more often than not, but I'm starting to kind of get a bit of interest in it. So dermatophyte infections are rarely invasive, but systemic therapy is indicated when they involve the scalp or nails, when you have cutaneous dermatophytosis, which presents with extensive lesions, or when you have a lack of response to topical therapy. And before 2016, we didn't really have much. We found that dermatophytes generally responded to first-line oral agents, which were or are terbinafine, griseofulvin, and to a lesser extent the azoles. But since 2016, there's been widespread reports of resistance to terbinafine, and we now know that's likely to be due to Trichophyton mentacrophytes genotype 8, or what we now call as Trichophyton indotinei. So this was a headline that caught my eye when I was doing a bit of a search to try and find some things. This came out in just last month, which was a bit of a headline to Australian dermatologists to urge them to consider doing genetic testing to determine whether these isolates that they're seeing are actually resistant to terbinafine. So we know that resistance in dermatophytes is an emerging global public health issue. And I myself have seen, and as I'm sure has many other diagnostic laboratories, they've a demand to perform antifungal susceptibility testing on dermatophytes. The trouble is that, unfortunately, comparing results between many of the studies that have come out in the literature is actually really challenging because lots of different methodologies have actually been used. The main methodologies that are in the literature are broth microdilution methods, agar-based disc diffusion, agar-based gradient strips, which we often call e-test strips after the original manufacturers, and then agar-based screening. And I'll talk to most of those now. So as I said, there's small differences in methodologies can lead to quite variable results. And so it's difficult to kind of get an understanding of the trends. And these differences can be small differences in your inoculum concentration, the incubation temperature, the time, your median formulation, the thickness of your agar, whether you interpret your endpoint at 50% or 100%, whether you read the results visually or spectrophotometry. But the other thing that's really important to know with susceptibility testing of dermatophytes is you actually really need to have an accurate identification of your organism to begin with. And then with that and the performance of antifungal susceptibility testing, it's hoped that that can then help guide treatment strategies and monitor resistance trends. So if I start with an explanation of broth microdilution testing. So this is the gold standard. In this methodology, you have serial two-fold dilutions of drugs, which are prepared in liquid medium and aliquoted across microtiter plates. And then those microtiter plates are inoculated with a standardized number of organisms, which are then incubated for a prescribed period of time. And then at the end of that period of time, you determine your minimal inhibitory concentration. And there are two reference groups, the Clinical and Laboratory Standards Institute and the European Committee on Antimicrobial Testing's susceptibility testing. And both these groups have published guidelines for dermatophyte susceptibility testing. So preparing these plates is technically quite demanding. It takes quite a lot of time to prepare the plates. You can store the plates in batches, but you need to store them at -80 degrees, which everyone who works in a lab knows that -80 degree freezers are prime real estate. They also require quite extensive QC on a regular basis. So this type of a method is not really broadly applicable to many routine diagnostic laboratories. As I said, there's small differences in methodologies can lead to quite different results. These are the two reference methods, and I've broken down the differences, and this is applicable for dermatophytes. So if we look at the two plates, the CLSI uses a U-shaped plate, UCAST uses flat bottom plates. The CLSI has a concentration of inoculum which is 100 times less than that is recommended by UCAST. They also use a median which has 10% less glucose than, or 10 times less glucose than the UCAST, and UCAST recommend for dermatophytes that you actually also add cyclohexamide and chloramphenicol to your RPMI medium. Incubation temperatures and times are quite different. As to the endpoint reading, UCAST recommends 50% endpoint reading for all dermatophytes. CLSI recommend an 80% endpoint for reading of the terbinafine and itraconazole, voriconazole, posaconazole, etc., but a 50% endpoint for reading fluconazole. CLSI recommends visual reading, UCAST spectrophotometer. Neither of these methods have breakpoints for any of the dermatophytes, but the UCAST have proposed tentative breakpoints just for Trichophyton indotinei and Trichophyton rubrum. This slide here just shows you what those tentative ECOFs are for these four drugs. Itraconazole, it's the same ECOF, but you can see that terbinafine, it's 0.125 for indotinei and 0.03 for terbinafine. So, sorry, for rubrum. So an ECOF, if something's deemed to be non-wild type, that suggests that the organism is likely to harbour a resistance mechanism and it may respond less well to therapy. And whilst there are no breakpoints for either CLSI or UCAST, it's generally considered that if you have a terbinafine MIC of greater than or equal to 0.5 milligrams per litre, then that would suggest that the isolate is likely to be considered resistant. So this review came out just this year, which was a systematic review by Gupta and others published in Antibiotics, which looked at terbinafine susceptibility for indotinei and Trichophyton rubrum isolates. The first two rows, so the green and the blue, are summary of CLSI-based MICs based on CLSI methodology, and the bottom one is based on UCAST methodology. So certainly many more results based on CLSI, but these two the differences between the two graphs are the endpoint reading of 0.5 as your, 50% as your inhibition versus the middle graph where you have used 90% inhibition as your MIC. And you can see that if you use the 0.5 as your indication, depending on your interpretation, you can see that if you use 90% inhibition, over 80% of these isolates would be deemed resistant if you use a value of 0.5. Far fewer isolates, far fewer isolates by UCAST and even by rubrum, and many fewer that actually have deemed resistant to terbinafine for rubrum. Now, in our own laboratory, Mariam Rowderbury, who has been working with us, has performed CLSI-based susceptibility testing on 47 molecularly confirmed Trichophyton Indotinei isolates, using the requirement of 80% inhibition, which is recommended by CLSI. And of those isolates, 66% of the isolates were found to have MICs of greater than or equal to 0.5. And all of those isolates were found to have MICs of less than 1 milligram per litre for itraconazole, which would be the alternative treatment that's probably recommended for these types of infections. And in fact, 68% of them have MICs of less than or equal to 0.125. So moving on to the next methodology, which is agar-based disc diffusion. So in this method, paper discs are infused with a known concentration of the antifungal agent, which is then placed onto the agar surface, which has been inoculated with a lawn of your organism and again incubated. And following the incubation, you measure the inhibition zone diameter. So the diameter at the point of marked reduction in growth, so about 80%. So this method is very quick and easy and inexpensive to perform, doesn't require any specialised equipment, and it can be a really useful method in resource poor settings as a way of determining whether you're likely to have a resistant isolate. So the drawback is they don't provide you an MIC, and you've got to remember that inhibition zone diameter will vary depending on your concentration of drug on the disc, but they do, the literature suggests you get good results correlating well with MICs. This paper here, published in 2015, actually published some kind of guidelines for whether an isolate was likely to be considered sensitive, intermediate sensitive, or resistant, using agar-based diffusion. I've put in here the concentration of the drugs that they used. So if an isolate had a zone of greater than 26 millimetres, that would indicate that the isolate would likely to be considered susceptible, but the terbinafine concentration was 2 micrograms. These pictures here have been given to me by Sarah, who does disc diffusion testing with both terbinafine and itraconazole using the NeoSensitab discs. And in these discs, the terbinafine concentration is 30 micrograms, so quite a lot more concentrated than that last slide. Shown down the bottom, we've got an interdigitale strain and Mentagrophytes and an Indotinei strain. And you can see that both the Mentagrophytes and interdigitale isolates have very large zones of inhibition against the terbinafine disc and similar zones against itraconazole, whilst the Indotinei isolate has a very small zone for terbinafine, but a nice zone for Indotinei, for interdigitale, itraconazole, suggesting that it would likely to respond to itraconazole. Next, moving on to agar-based gradient strips. So these are often called e-test strips. They're commercially available strips which are impregnated with a predefined concentration gradient of a single antifungal, and that strip is placed onto an agar plate which has been inoculated with a lawn of your test organism. Following incubation, the MIC point is read at the point at which your ellipse of growth inhibits with the strip. The great thing about this type of approach is you've got great flexibility in testing antifungals with agar-based or with gradient strips available for most antifungal agents. It's also, the method is unaffected by the drug properties or varying growth rates, and the disadvantage, I guess, is you do require some expertise to actually read where that MIC zone is. Shown here again, images thanks to Sarah's lab. We've got 2 Trichophyton Indotinei isolates, one which has a nice low MIC of probably 0.06 to the terbinafine, whereas this second isolate has, if we look for the ellipse, it's probably around about the 3 or 4 milligrams per litre. mark. And then the last method I'll talk about is agar-based resistance screening. So this method was really initially developed to screen and identify initially azole-resistant Aspergillus fumigatus isolates, and then subsequently also echinocandin-resistant Aspergillus fumigatus isolates. And the method was standardized and endorsed by UCAST and can be found in this particular lot. In this method, the antifungal agent is actually added to the agar at a particular concentration, and if your organism grows on that agar infused with the drug, then it would you assume that your isolate is resistant. So it has since been developed for phenotypic detection of resistance in Trichophyton species, but it's important to remember that the results should always be verified with the gold standard of broth microdilution testing. But it's a good screening method. So these images came from a paper which is about to be, or it's in press at the moment. So these are the little plates. I always think they look a little bit like little eyeshadow packets. They're quite small. We've got the growth control well here, which has no antifungal agent. Then we've got two different terbinafine concentrations, a 0.016 milligrams per litre, and this well down the bottom at 0.125 milligrams per litre, and then itraconazole at 1 milligram per litre. So this first isolate would be considered susceptible, because it's only grown on the growth control well. The middle picture, we have a low-level terbinafine resistance in this strain with some growth here, but not at 0.125 mg. And then the last picture, you've got a high-level terbinafine resistant strain. You've got very tiny little microcolonies that are appearing on the itraconazole well, but these they mention you ignore that. So I thought I'd just give a little brief overview of terbinafine, its mode of action, and where resistance is likely to be found. So terbinafine is it's a fungicidal drug that works by disrupting the early stages of ergosterol biosynthesis by inhibiting squalene epoxidase enzyme and preventing squalene oxidation. This leads to toxic accumulation of squalene and depletion of the ergosterol in the fungal cell membrane, disrupting membrane integrity and function, and ultimately leading to cell death. So, as Sharon's touched on this already, with what we see in Trichophyton indotinei, in particular, terbinafine resistance is primarily a result of the development of point mutations in the squalene epoxidase enzyme. And these structural changes in the amino acid sequence result in a reduction of the ability of terbinafine to actually bind, but it doesn't interrupt the ergosterol biosynthesis pathway. Now, many resistant isolates do have point mutations in the squalene epoxidase enzyme, but studies have found that you can have isolates with identical mutations that have quite different MIC values. And so the literature suggests that there are other mechanisms that may contribute to terbinafine resistance, and these include overexpression of the efflux channels, biofilm production, overexpression of heat shock proteins, and overexpression of the SAL-A gene, which results in degradation of terbinafine. So again, I'd go back to this systematic review, which looked at these gene mutations and their distribution in both Trichophyton indotinei and Trichophyton rubrum. And if we look at Trichophyton indotinei in particular, there were 212 isolates, and by far the most frequent amino acid substitutions occurred at position 397, so a switch from phenylalanine to leucine, followed by the next most frequent was this alanine to threonine at position 448, and then third was a combination with isolates that had both of these polymorphisms. Now, alanine, the reason I've put an asterisk next to alanine 448 and threonine is that this mutation is found to be unique to Trichophyton indotinei isolates, and it's actually also been detected in isolates that are susceptible to terbinafine. So the reason it's thought to potentially not necessarily affect terbinafine resistance is it's located not opposite the terbinafine binding pocket, and so it's not necessarily crucial for terbinafine resistance, but it has been associated with interfering with ergosterol synthesis. So it's thought that perhaps this mutation may actually contribute to azole resistance in these indotinei isolates. Looking at Trichophyton rubrum isolates, again, the most common mutations were the same, located at positions 397 and 393 amino acid positions. So given the fact that in order to perform susceptibility testing, you need a pure culture, it takes, as Sarah has indicated, it can take quite a few weeks sometimes to actually grow dermatophyte, and then a little bit longer again to get it to sporulate to be able to perform antifungal susceptibility testing. The idea of being able to potentially detect terbinafine resistance by molecular methods is quite appealing, because we in theory could get a result much more quickly, which allows timely treatment decisions to be made. And when you consider that 2/3 of isolates worldwide of Trichophyton indotinei have been reported to have these two amino acid substitutions, and that they do correlate, these substitutions do correlate to high terbinafine MICs. Again, it makes these particular targets quite an appealing target for molecular detection of terbinafine resistance. And a review of the literature shows there's numerous in-house PCR-based assays which do detect these mutations, but they do rely still on culture. So they're not going to be that expeditious, but they're quicker than probably doing susceptibility testing. So Sarah touched on the Dermogeneous assay, which is for species-based identification, but Pathognostics have also released a Dermogeneous resistance assay, which picks up 5 common amino acid substitutions in Trichophyton isolates listed here, so all at positions 397 and 393. The assay can't actually differentiate between what those mutations are. It simply uses melting temperature analysis to determine whether your isolate that you're studying is either wild type or non-wild type, which is shown here in the picture. But the results do correlate well with broth microdilution testing. So I guess in conclusion, there is absolutely no doubt that the global spread of Trichophyton indotinei infections is a wake-up call to action, that antifungal susceptibility testing of dermatophytes, dare I say it, is important. It's important for early diagnosis and the ability to initiate targeted therapy. It's also important to monitor local epidemiology and empiric therapy. Gradient strips, distaffusion, agar-based screening methods are useful methods for routine clinical microbiology laboratories. By performing it, you have the ability to facilitate earlier change to appropriate treatment rather than waiting months for a patient perhaps not to respond before you change therapy. But it's important that these methods are verified with broth microdilution reference testing. With Trichophyton indotinei infections in particular, there does seem to be a clearer relationship between in vitro results and in vivo responses, but this is not necessarily the case for other species. But and I guess the last thing is to say that there really is a need to do research, and the value of of susceptibility testing to improve clinical practice and actually see if it helps us with the management of dermatophyte infections. And with that, I'll stop sharing.
Catriona, that was very comprehensive. Thank you for that. We are running a little bit late, so we might move to the next speaker, and it gives me great pleasure in introducing Dr. Sunil Dogra, who is from Chandigarh in India. He's a very busy dermatologist, and we do appreciate him giving up his time to talk to us about treating drug-resistant Trichophyton infections. Thank you, Dr. Dogra.
Good evening, everyone. Hope I'm audible, Sharon. Yeah,
Yes,
my slides are visible, right?
Yes, the slides are visible.
Right. So good evening, and thank you, first of all, Sharon and Benton, for giving me opportunity to get connected with the colleagues from Australia and New Zealand who have interest in mycology. And I'll be speaking on treatment of resistant Trichophyton infection, primarily endothenia. Please excuse my bad throat. And I agree with what Catriona concluded, that it is a wake-up call for world. We have been facing this infection over last 10 to 12 years, and gradually now it is finding its way in most of the countries across the globe. So I work in a tertiary care center which is north of Delhi. We have a dermatology department which runs OPD almost every day, except Sunday. And daily we see about, say, 800 to 1,000 patients. And out of these, about 20 to 25% patients pertain to dermatophytosis. This is very important article, probably first in the Indian literature, when we started seeing these cases in India. At this point in time, I was editor-in-chief of this journal. This was first issue of 2016. And in this issue, in case you can read, these are small letters, but I'll read for you. It says that dermatologists are perplexed by a complex behavior of dermatophyte infections. Many postgraduate MD thesis research projects on chronic dermatophytosis are underway at many centers in India. In almost all major regional and national conferences in India, a dedicated session is being planned on chronic dermatophytosis. And we will not be surprised if in near future, theme-based conferences happen exclusively to discuss the ongoing menace. The tinea corporis cruris, once considered to be easy to manage skin condition, is gradually becoming a dermatologist's nightmare, and it has become a disease like any other chronic skin disorder like psoriasis, vitiligo, and pemphigus. So that was about 11 years ago. And now the situation has exploded manifold, and all these so-called predictions have come true. Now we have MD, PhD thesis ongoing almost all the years. We have dedicated dermatophytosis session in all the conferences. We have theme-based national and regional conferences, even international conferences being held in India, and many research projects ongoing. So that is the importance of dermatophytosis and the dermatophytes pathogens which have assumed in the dermatology spectrum. So this is a common term which we use for what type of infection which we see these days, recalcitrant dermatophytosis. And it is a generic term which can refer to relapse, reinfection, persistence of infection, or even chronic infections. This study is about 4 years back, 2021. This was a multicentric study in India. We conducted over 2 weeks, and we found that out of all dermatophyte cases, near 1/3 had chronic and recurrent infections. More than 50% had history of topical steroid misuse, either themselves or taken from the over-the-counter. In India, it is easy to get topical medication and you don't need prescription from the doctor. So there is a lot of topical steroid misuse. And majority of the patients had multiple site involvement. So the main features of this so-called epidemic-like feature is that There is increasing frequency of dermatophyte infection over last 10 to 12 years. Most of the infections are chronic and recalcitrant. There is change in the fungal species from T. rubrum now to T. indotinea, and there is incomplete or no response to topical and systemic antifungals. There are various hypotheses proposed for these reasons, but we are still working on the what has led to such epidemic-like situation in the India and now also over the rest of the world. So these are the spectrum of cases which we see in our clinical practice. Almost all age groups are affected. No body site is spared. Sites like scalp in adult, which was never involved in tinea corporis, now it is almost all patients who have face involvement. The dermatophytes are extending inside the scalp also. Even infants, toddlers, all are being affected, and patients have extensive body involvement. You all are experts in this. I'll just like to draw your attention that in 2012-13 studies, T. rubrum was still the predominant isolates in most of the studies from India. But from 2015 onward, T. mentagrophyte interdigital complex dominated in all the studies from various parts of the country. And now it is being more than 90% isolates are T. indotinea, what all the studies coming over last 2 years. So this is an emerging new species which is of global concern. And now in the latest analysis which we did with our mycology department, more than 90 to 95% isolates were T. indotinea from all dermatophyte cases. It has spread to more than 40 countries now, though we understand that the problem possibly originated from India, and majority of the cases still, because of being such a big country, are from India of T. indotinea. Another phenomena which we have observed is, as detailed discussed by Catriona, is rising MSC to antifungal drugs and drug resistance. Our center was the first to report the resistance mutation in the terbinafine. Resistance were reported for the first time from our center. And then there were multiple studies from other parts of the country which also documented terbinafine resistance in T. mentagrophyte interdigital complex. And now there are many studies from rest part of the world documenting at least 2/3 of the isolates of T. indotinea exhibiting resistance or high MSC to terbinafine. So if I say about India, almost 70% of the dermatophytosis cases, they have possible resistance to standard antifungal therapies, more so to terbinafine. It has led to a situation of epidemic-like scenario. The main reason behind this is a shift in the pathogen, which is now T. indotinea. And over last 4 to 5 years, it has almost dominated over T. rubrum and T. mentagrophyte all over the country. Coming to the clinical characteristics, the lesions, as Sharon mentioned in her talk, are very inflammatory, associated with burning sensation. Almost all body sites are involved. Face involvement is quite common, which was rarely seen earlier. There are many atypical forms which are being seen, which were unheard of in dermatophytosis. Multiple body sites are involved. All age groups are being affected. Generally, the commonest clinical type which we are seeing is tinea cruris associated with tinea corporis. There can be 2, 3, or multiple anatomical site involvement. Sometimes patients have involvement of the body from head to toe, what we call erythrodermas. And now dermatophytosis has become a great mimicker in medicine, like what we used to read and discuss about syphilis and sarcoidosis. It can have variety of presentations and it can mimic almost any skin condition, and it is now a differential diagnosis of almost any skin disorder. It has so varied presentation these days. And beyond that, it has profound effect on quality of life of patients. It has added huge financial burden for the patients and their families. And now we have patients who have been coming to us or who have history of dermatophytes for last 7 to 10 years. So it is, I would say, dermatophyte is no more a acute infection. It is a chronic infection. something what deep fungal infections are. So that is the unfortunate state of affairs. Just a glimpse about various clinical presentation. It could be eczema-like, psoriasis, impetigo-like, lupus erythematosus-like, molluscum-like, Mazzocchi granulomas, cystic lesions, tinea pseudoimbricatas, uh, then eyelid involvement, rosacea-like presentation, blisters, pustules. These forms we never read in the textbook. I'm sure all of you in your textbook would have never encountered with such clinical presentations. So all these and many more varieties are being seen in the clinical practice. So the main question is how to treat. Uh, and we the dermatologists are really finding it a quite challenging condition. At one point of time, tinea was perhaps one of the easiest disease to be treated by a dermatologist. It was never discussed in any of the dermatology conferences prior to 2010 because no one thought it need any attention that we need to discuss it. But now it has become one of the most difficult condition for us to treat because of its recurrent nature, poor response, and chronic disease course. So when we discuss about treatment, the counseling, the education of patient is very, very important as far as chronic or recalcitrant dermatophytosis is concerned, because fomites and their daily habits, it plays a great role in spreading infection to other family members and also for the persistence of infection in the same person. So generally we tell them to take daily regular bath, to dry their clothes after washing in the sunlight, iron them from inside out. They should change their linens and other clothing quite regularly. They should wear loose clothes. Obese patient, we advise them to lose weight. Most important, we tell them to complete the course of treatment and not stop just at some clinical improvement, not to use topical corticosteroids or over-the-counter available topical steroid antifungal combination, not to share prescription with other family members, and to come for follow-up in case they have any problem. We have made several patient information leaflets in almost all languages because in India we have a language changing in every state for the information of patients. So we do give to these patients when they come to our OPDs. Uh, about the topical antifungal, which what all option we have, the conventional imidazole, the older ones are category B drugs. They can be used in pregnancy also. Then we have newer as imidazoles like sertaconazole, laliconazole. They are anti-inflammatory in addition. Then apart from that, there are allylamines, morpholines, hydroxypyridinones. The example is cyclopyroxolamine, amrolfin, and these topical antifungals are available in the form of creams, lotions, ointments, powders, and sometimes soap and shampoos also. And they are used depending on the site involved and the extent of body surface area involvement. Sometimes we also use topical salicylic acid along with benzoic acid over palms and sole when there is thick uh, tinea manum or tinea pedis. So here you can note that the older imidazole are category B, and so is the terbinafine, cyclopyroxolamine, and butinafine. So how do you decide topical antifungal? The choice depends upon the pharmacological property of drug, the site and extent of the dermatophyte lesion, the patient's age, if there are any comorbidities, any history of prior antifungal use. And in case of topical antifungal, we generally prefer topical azoles because they have anti-inflammatory, bactericidal, antibacterial, and broad antimycotic properties. We generally advise our patient to apply topical antifungals even beyond lesions because sometimes there are small lesions beyond the main borders which may not be visible. So we tell them to apply about 2 to 2.5 centimeter around the lesions. Uh, Azoles, they have reservoir, the newer azoles in addition have reservoir effect, meaning that their effect can last longer and even a single day application can be sufficient. They have anti-inflammatory properties. Then we have sporicidal topical antifungals like terbinafine, amrolfin, cyclopyroxolamine, which again are very effective and they are effective formulation to be combined with systemic antifungals. Whitfield ointment containing salicylic acid is sometimes used in tinea pedis and manum. Lotions are useful in widespread disease and in scalp involvement. Emollients, they are very important, mean coconut oil or any moisturizer to take care of the skin barrier restoration. And antihistamines are required almost all patients because these lesions are associated with a lot of itching and burning sensation. Now coming to the systemic antifungal therapy, uh, this was the first treatment guideline which uh, was published after we started having cases of recalcitrant dermatophytosis in India. This was in 2018. And prior to this, there was no specific treatment guideline because we never felt that there was any need for treatment guideline in dermatophytosis. There was some treatment guideline published in American Journal, but that too in early 90s. So as per this and what we used to do 5 years back, the new cases we were treating with terbinafine and itraconazole, either 250 milligram daily or 200 milligram daily. And the recalcitrant cases, about 5 years back, the proportion of recalcitrant cases was not much. It was near about 30% of the all cases. And there we were giving itraconazole again 200 milligram, but for longer period. And in some cases, we were giving 400 milligram to start with, and later shifting to 200 milligram of itraconazole. At that point in time, some cases which were presenting to us for the first time were responding to terbinafine. Now, if you see at this table, this guideline came in 2020, and still the treatment duration is mentioned is 4 weeks, both with terbinafine and with itraconazole. But now in 2025, 4-week treatment is highly insufficient for these cases, and we don't treat any case less than 8 weeks, maybe more in some of these cases. So the dose and indication remain the same, but we are seeing that the duration of treatment is gradually increasing as we are progressing along this so-called epidemic of dermatophytosis. In case you have tinea pedis, majority of the patient will need topical and systemic antifungal combination, and tinea pedis with alone topicals will be difficult to manage. Tinea cruris and corporis, in case there is only a localized lesion, which is difficult to see these days, we can treat with topical antifungal alone, and the choice could be between azoles, terbinafine, or the cyclopyroxolamine. In case of extensive and recalcitrant lesions, which are the most of the cases these days, we combine topical with systemic antifungals. Whenever there is a vellus hair involvement, vellus mean soft, non-pigmented hair as we have over the face, neck. So these are the cases which will again not respond to topicals, and we will have to treat with the systemic antifungals for 8 to 12 weeks, how we treat tinea capitis. Patients who have tinea incognito, who have used topical corticosteroids, again need a relatively prolonged course of antifungals, and preferred here is itraconazole. In all cases, we give antihistamine, as I mentioned, moisturizers, and salicylic acid in palmoplantar tinea involvement. In pediatric age group, topicals can be used, and almost all classes of topicals can be used. There is no systemic absorption. When we have to select the systemic antifungals, the dose should be based on weight. Above 2 years of age, we can choose between griseofulvin, terbinafine, and itraconazole. In case there is scalp or tinea capitis involvement, griseofulvin is preferred. Otherwise, for the tinea corporis and cruris, terbinafine and itraconazole can be used. In these recalcitrant dermatophytosis, we have observed that nail involvement is not common. Somehow we have extensive involvement of the skin, even face, scalp, but nail involvement is seen in only a small proportion of cases. And in case there is nail involvement, then terbinafine or itraconazole is preferred. In case there is a tinea below 2 years of age, then fluconazole is preferred over other drugs. In patients who are lactating, topicals can be used, but ointment should be avoided over the breast because they have mineral paraffin, and it may get exposed to the infant who are breastfeeding. In case of systemic antifungals, fluconazole is safer as compared to other oral antifungals. In case of pregnant patient, terbinafine can be used if dermatophytosis is very extensive, but it should be avoided in first trimester of pregnancy. In elderly and those patients who have comorbid conditions, this patient was mistreated as a case of eczema, then psoriasis by a general practitioner, given a lot of corticosteroids, methotrexate, and then he presented to us with such exogenous Cushing syndrome and this tinea incognito. So he was managed with the help of endocrinology department, and we managed tinea with itraconazole and topical antifungals. And in these patients, we have to be careful. We must monitor LFT at the baseline and at a periodic interval. These are the antifungals which we can select in special situations. In case of pregnancy, as I mentioned, if disease is very extensive, terbinafine can be given, but it should be avoided in first trimester. And most of the cases, as far as possible, should be treated with topical antifungals. Lactation, fluconazole is safer option. Patients who have liver dysfunction, terbinafine should be avoided. Fluconazole can be given. Patients who have chronic kidney disease, again, terbinafine and itraconazole are not safe. Fluconazole is a safer option, but terbinafine can be given with low dose with the creatinine dose adjustment. Cardiac patient should not be given itraconazole because it can increase the congestive heart failure. Fluconazole is a safer option. Elderly patients, itraconazole should be avoided because they are on multiple drugs, and itraconazole has drug interaction with almost any drug. So terbinafine is a safer option over there. In children above 2 years, any oral antifungal can be given. Below 2 years, fluconazole is a safe option. This is a very interesting study recently published by our center. Here what we observed that patient who had uh, mutation in the squalene epixoid gene and who were treated with either terbinafine or itraconazole, beyond 8 weeks, they had good clinical response as compared to those patients who were treated for 4 weeks only. Though majority of the patients these days we treat with itraconazole, but some patients who presented to us for the first time were also given terbinafine. And patients who had disease duration less than 6 months, they had better cure rates and reduced recurrence than those patients who had disease for more than 6 months and chronic relapsing disease. And we could not establish a very direct kind of correlation between antifungal susceptibility test, which is being done in our mycology department, and the clinical outcomes. Though most of these patients were, as I mentioned, were treated with itraconazole, and we gave them for up to 8 weeks. This is another interesting study. It has a lot of carry home message. The study from Delhi. They studied these patients with itraconazole 100, 200, and 400 milligram daily, and they studied the cure rate. Interestingly, they found that there was no difference between 100 and 200 milligram dose of itraconazole in achieving the cure, but 400 milligram had significantly higher cure rate than 100 milligram and 200 milligram. The total duration of treatment was shorter in 400 milligram than 100 and 200 milligram, and there was not much difference between 200 and 100 milligram. Relapse rate was overall 47%. So regardless of what dose we give and how long we give, near about 50% patient had a relapse, and they were similar across all age groups and all treatment groups. The safety profile, no patient had to be discontinued, even those who were given 400 milligram. So 200 milligram had a higher cure rate than 100 milligram, relatively higher, but 400 milligram had higher cure rate, but the cost was very high. So it may not be worthwhile to give 400 milligram to all the patients, but in those cases where we are not finding response with 200 milligram of itraconazole, 400 milligram may be tried in selected patients. So in summary, how do we manage terbinafine resistant T endothelial dermatophytosis? Patients who have partial terbinafine resistance can be given terbinafine for longer periods, say up to 12 weeks, or a higher dose can be tried, 500 milligram per day. The best is to give itraconazole, and again, these days we need to give them for at least 8 weeks and sometime up to 12 weeks also. Some patients we are giving 400 milligram in the initial 1 to 2 weeks and then shifting them to 200 milligram. Now we have suba-itraconazole, which is available in our country and in many other parts of the world. It has advantage over the conventional itraconazole that it has better bioavailability and better pharmacokinetic activities. It can achieve better clinical response and cure rates. But again, the treatment duration remains the same. The new cases, it is 4 to 6 weeks, 130 milligram once a day. And patients who have recalcitrant and chronic disease, we give them for 6 to 8 weeks. But here, if you say, as per these guidelines, it is again advisable to extend treatment 2 weeks beyond achieving the complete cure. So gradually we are extending from 8 weeks now to 10 weeks, and 2 weeks beyond the clinical cure has been achieved. Now there is an advocacy to give itraconazole even up to 10 weeks. This is a recent study which was quoted by earlier speaker also. This is my last slide almost. So here I want you to see this option, second line and third line treatment. So patients who do not respond to itraconazole, though fortunately almost all our patients are responding to itraconazole. We may have to give them for longer period of time, but there are few patients who have not shown good response on itraconazole. I would say there is a partial response, and then we had to shift them to voriconazole. And here also authors, this is a study by authors from Canada, London, Denmark, Israel, and various other countries, including India. And they recommend that patients who do not respond to itraconazole may be now considered for voriconazole and maybe for posaconazole. We would like to avoid giving these drugs because these are very useful for systemic mycosis, but we are heading toward a situation when maybe itraconazole may not work for recalcitrant dermatophytosis one day. I hope that situation never arises, but these are the already guidelines which have depicted that this scenario may emerge in near future. So with this, I conclude and I acknowledge my colleague, Dr. Shiva Prakash, whom some of you may know. He is a professor in charge of mycology division at our institute. And our institute mycology department is also a WHO referral center for fungi of medical importance. So thank you once again, and thank you, Sharon, for giving me this invite and to get connected with all of you.
Thank you very much, Dr. Dogra. That was very illuminating, and you know, it's amazing how one can learn and continue to learn all the time. I know it's a bit late, but Van Hoek, shall we do 2 questions? What do you think?
Sure.
Yeah.
Maybe let's take this one.
Yes.
Who finds that whenever he is uses ITS to identify Trichophyton species, and then using blast analysis using NCBI blast, he finds that the percentage match for the 3 species are all the same. Mentagrophytes, Indotinei, and Interdigitali. So he's asking for some guidance on more accurate identification.
Sarah.
Shall I? So my recommendation was to avoid using NCBI blast because GenBank has many problems, but with the dermatophytes and particularly the Mentagrophytes complex, there's been sort of so many reclassifications that many of the sequences in there have old names attached to them or just incorrect names, and so when you use the BLAST algorithm, you're not going to be able to get an accurate identification. So that's why I made the point that really to use ITS sequencing, you need to be comparing it to those reference sequences, which you can download from GenBank, and the details about how to get them are all in that Erlash Journal of Fungi paper published in 2022. and perform your comparisons against those reference sequences to get an accurate identification.
Thank you. And then a very interesting question from Malcolm Richardson, maybe for Dr. Dogra, whether or not we should be advocating combination treatments such as a topical and a systemic.
Combination of topical and systemic. Okay. So almost all cases which are not localized, the combination of topical and systemic is required. And generally we choose topicals which these days which are anti-inflammatory properties like neurazoles and also cycloperoxylamine, or sometimes we also use terbinafine. But only those cases where disease is very localized and presenting for the first time, topicals alone may suffice. But in the current scenario of recalcitrant dermatophytosis, most of the patient will need combination of topical and systemic antifungals.
Thank you. Sharon, you can close. I think it's late.
Yes, okay. Well, actually, maybe just one more question at the risk of prolonging this. Is infection control a problem? Might direct this to Dr. Dogra. In some places in Australia, they're seeing more cases and wondering about transmission in hospitals. Have you seen this in your practice?
So we are seeing clustering of cases in the families, but not in a hospital spread of infections. No, like what we see with scabies, we don't see with dermatophytosis because it's a slow evolving infection. There are some patients where are only one or two family members affected, but then there are some families where multiple members are affected. And mostly it is seen in those families which are living in a overcrowded spaces. There is a lot of sharing of fomites, and it is relatively more in the, I would say, low socioeconomic status, where the living standards are not that adequate.
Okay, so it's more community problem than a hospital
Yes,
problem.
yes, it's
Yeah.
more of a community problem.
Yeah. Okay. Well, on that note, it is late, and I do apologize for going over time. Thank you all for being here. Please join me in thanking all the speakers and the secretariats for having organized this session. We have a final session in November this year, which the AFWG will be presenting, topic to be defined as yet. So thanks again, and see you next time.
Thank you.
Thank you, everyone.
Thank you. Thank you,
Thanks,
Thanks,
everyone.
Sharon. Thanks,
Sharon,
Catriona.
Catriona, and
Thank you.
Yeah, thanks,
Sarah,
Banhok.
and to Sunil.
Thank
And
you, Ben.
okay.
Okay,
Thank
All
you.
bye-bye.
right.
Thank you. Thank
Okay. And thanks,
you.
Inga, if you're
Thank you. Have a
still
great
there.
evening. Bye. Bye. Bye.
Bye.
Thanks, Sharon.
Bye, Banhok.
Bye-bye.
I think
How do I leave?
I'm not sure whether I should wait for Inga to come back.
Oh, I
Banhok,
see.
why don't you leave and I'll try to leave. If I can't,
Okay.
if I
Have
can't
a good
leave,
night, Sharon.
yeah. You too.
Bye-bye.
Okay.
Bye-bye.
Bye. I think it's all right.